Now they
get started as people continue to join. So good morning, everybody. I'm Anuradha Budu. I'm the program manager at NCI's liver cancer program. Welcome to everyone this morning, and thank you for joining our LCP seminar series today. We're happy to welcome Dr. Jesper Andersen from the University of Copenhagen, and we're looking forward to his presentation. Before I intro Jesper, just a quick note that our LCP seminar series will have a short hiatus during the summer. We will reconvene in the fall. Our first seminar in the fall will be on September 30th, and Eli Pekarsky will be our speaker from the Hebrew University in Jerusalem. And this and upcoming seminars can be found on the LCP website. And of course, announcements will be sent out in the coming months. So we hope you can continue to join us in the fall. So for today's seminar, if you have any questions for Jesper, please add them to the chat box or turn on your mic at the end of the presentation, and we'll address your questions at the end of the seminar. So today we are very excited to welcome Jesper Andersen. And just a short intro here, he received his PhD in 2006 from the Department of Molecular and Structural Biology at Aarhus University in Denmark. He followed that with a research fellowship in the laboratory of Brett Hassel, who is joining us today at the University of Maryland. And then in 2007, he joined the NCI in Snorri Thorgeson's laboratory, was here with us as a postdoctoral fellow until 2014, when he was appointed associate professor in translational research at Biotech Research and Innovation Center of BRIC, at the Department of Health and Medical Sciences at the University of Copenhagen in Denmark. In 2019, he received tenure at the University of Copenhagen, and he's published more than 100 papers and book chapters and received several prestigious awards in cancer research, most recently from the Danish Cancer Society. He's also the co-founder of the European Network for the Study of Cholangiocarcinoma and a member of the International Cholangiocarcinoma Research Network. So Jesper's group utilizes genome-wide approaches in modeling stratifying patients for advanced diagnostic and prognostic markers and novel therapeutic options. His research team is focused on understanding the mechanisms that contribute to tumor heterogeneity, drug resistance, and how to leverage this molecular data to evade resistance mechanisms with the hope of impacting clinical management and improving patient outcome. So today, Jesper is going to speak to us about oncogenomics in cholangiocarcinoma, patient stratification, and predictive biomarkers. So welcome, Jesper.
Thank you very much. It's a great pleasure to be with you again, even though it's virtual. I'd like to thank Xing Wang and Tim Gritton and you, Anu, for the kind invitation last year already to speak at your liver cancer program series. And of course, all of you for attending this virtual presentation. As Anu said, my name is Jesper Andersen, and I'm the head of the Andersen Group at Biotech Research and Innovation Center BRIC here at the University of Copenhagen in Denmark. But I've spent much of my younger days in both Baltimore as well as in Bethesda with you guys at NCI. So in the next hour, I will be discussing with you the current, what I believe is the current state of oncogenomics in cholangiocarcinoma and patient stratification and predictive markers. That's frozen. There we go. And my talk is, so I will have a specific focus on biliary tract cancer or cholangiocarcinoma in this presentation, which is divided into three parts, as you can see on the screen. Part one is a little tour de force on historical stratification of intrahepatic cholangiocarcinoma into where we currently are with driver genes and therapeutic implications according to our beliefs, diagnostic and prognostic markers, or specifically the lack thereof, and our work on serum IL-6 as a prognostic biomarker, and IL-6 receptor axis as a therapeutic target in biliary tract cancers, And then I will switch a little bit at the end over to HCC to describe some novel data we're trying to publish right now on the development of serum lipidomics as a diagnostic score for NAFLD-HCC. So the first application in patient stratification was in cholangiocarcinoma a number of years ago when I was in Snorri Thurgeson's lab at NCI. We then built a gene classifier, and we argue that the lack of genomics-guided therapeutic options and the appealing lack of these limitations of biomarkers, we have to remember that it's actually only 7-8 years ago that we published this prognostic gene classifier for cholangiocarcinoma, and things have moved really fast since then, which I hope I can convey to you in the next few slides. This was a gene array study of 104 intrahepatic and perihilar cholangiocarcinoma with matched surrounding liver tissues. And we developed a prognostic signature comprising 238 genes, showing a significant overall survival as well as recurrence-free survival. However, as is the case for most gene signatures, it predominantly highlights patients associated with worse prognosis. As seen here, we have most of the different identifications in the poor prognosis class, such as inflammation, proliferation, overexpression of receptor tyrosine kinases, the RAF-RAP, ERK pathway, as well as KRAS mutations. So significant studies in the non-recurrent advances cases are still lagging. So these are all resected patients, and we have to remember that when we discuss most of the genomic studies, that they are not the 80% of 70 to 80% of non-resected cases. Nonetheless, we saw overrepresentation of inflammatory and proliferation-associated genes, as well as a typical cancer-related pathways, such as as I said, the receptor tyrosine kinases, MAPK and mTOR pathways, and I would like you to remember particularly the mTOR to later in the presentation. The key networks activated in cholangiocarcinoma associated with our classifier genes that have an independent survival performance, highlight a predominant dysregulation of beta-catenin, MYC network, TNF, and VDF ERB pathway genes. So indeed, we then further examine the protein levels by either immunohistochemistry on the left-hand side or a protein type array on the right-hand side, showing overrepresentation, or if you will, addiction of multiple cancer-related pathways in most of the cases. In the line of these two patient groups, we have the good prognosis referring back to the transcriptomic classification in the previous slide, and the poor prognosis, and then a repetition of another patient group on good prognosis and poor prognosis in marked in red. And in line of receptor tyrosine kinases, inflammatory pathways, and MAPK pathways, they are all overexpressed in these cancer types, in this cancer type. So you think from the genomic landscape showing a number of cancer-related pathways which are altered, and particularly a kind of oncogene addiction to receptor tyrosine kinases and MAPK inflammatory pathways, the therapeutic applications against these networks would present an advantage. However, when we look at the timeline of systemic therapies in biliary tract cancers, both chemotherapy as well as targeted therapies, most, if not all these studies, since the relative success of the ABC-02 have actually failed, and I marked in the red box the ABC-02 trial back in 2010. And then until we get into the Clarity trial that's still ongoing for approval, we have not really seen a major success except for penigatinib that was approved last year in the US, and have just gotten approval in Europe in second line. for FGFR2 fusion positive. So if you remember 2 slides back, the patient in the good prognosis survival group are presented only by immune-related pathways. So one could possibly argue that these type of drug categories should not be abandoned yet, but with proper selection of patients and possible combination and/or sequential trial designs target of several of these key pathways showing oncogenic addiction, we may actually improve the relative response. And this is many of the things that we in my lab and other labs are working on. Additionally, as seen on the right-hand side, there are a likely opportunity for many different more novel approaches, such as epigenomic dysregulation, the metabolic and immune-related pathways in this disease type. Several studies have attempted to predict the percentage of patients with targeted mutations, which for cholangiocarcinoma likely is around 50%, but it varies from studies to study. And whereas TKI trials have failed, as we just discussed in the previous slide, enriching patients with a specific targetable alteration increases the study for success. So in April last year, pemigatinib became the first approved drug in cholangiocarcinoma. We need to celebrate this since nothing much has actually otherwise been ongoing for this disease for the last 30 years, and particularly not since the last 10 years of the APCO2 trial. Pemigatinib, as I said, is now approved in the US for patients with unresectable local advanced or metastatic tumors positive for FGFR2 fusions, presenting the first patient stratification and predicted biomarker in this disease. And we also are awaiting the approval of Tibsovo against the IDH1 mutant tumors in cholangiocarcinoma. These examples are predictive of a specific patient group and stratifying patients into subsets, and therefore the response to the accompanying drugs could be achieved in comparison to past trials. To date, we have a number of published genome-wide studies that used integrating approaches of various layers of data matched to the same patient, both from you at the NTI with the Tiger LC, the TCDA core paper, as well as what I marked in the bold red, our own study, which I will go through in a second, and many other studies that have come out, as well as a number of single cell studies in the last year. Now, if we consider the likely main driver of mutations in intrahepatic cholangiocarcinoma, those probably will count TP53, as in most cancer types, at least 50% of all cancer types, IDH, as we talked about, 1 and 2 IDH, as well as KRAS. And integrating multiple platforms for the matched patient, we can construct network vulnerabilities to inform putative enhanced drug sensitivities in these patient subsets and stratify the patients. Not to go through this somewhat complex analysis workflow we went through in the study, but it is important to highlight that within the undetermined patient subset, we see enrichment of patients with the FGFR2 fusions. As seen here, we have IDH, KRAS, and TP53, and the undetermined. Determined they have neither IDH mutations, KRAS mutations, or P53 mutations, but we found later on that they have the FGFR2 fusions, as well as metal-13 amplification. And metal-13 is at the point when we started studying a relatively unknown gene with only 3 to 4 papers published. It's gotten a little more attention in the last 1.5 years. It's a metal transferase-like gene 13 that have been shown in 2 papers to methylate K55 on the elongation factor as currently the only target. If we look at the mutational exclusive grouping already in the Oncogenomics, as you can see, TP53, KRAS, and IDH are forming clear groups, and then we have a group that doesn't have any of these 3 mutations, and they are the ones that return undetermined and had or are shown to have the FGFR2 fusions. We see that the plot shows a clear separation in each of these mutant driver gene categories. This is clear in both the discovery cohort as well as in our validation set of patients, showing a markedly mutational exclusivity. In fact, if we look at the sum of somatic alterations for each patient subset, there is a marked enrichment of accompanying genetic alterations unique to each of the mutant driver gene subsets. So if you look at these numbers, each patient group are not only unique by its estimated driver gene, but also many of the accompanying mutations that are carried in this patient subset and not shared among the different 4 groups. These perturbations are recurrent and unique to the specific patient subset. And when we look beyond the low penetrant passenger mutations, the second tier mutations based on their significant penetrance in the disease often are involved in the epigenetic regulations with the main driver gene as shown over here on the right hand side. So the majority of recurrent genes are unique in each of these patient subgroups. We observed for the driver gene stratification that the intersection of genes encoding somatic variances demonstrate clinical significance, of course, both in the validation as well as in our 2 both in the discovery as well as our 2 validation subsets, as well as for time to recurrence. So therefore, the enrichment of underlying alteration demonstrates clinical significance. Interestingly, and likely important, the distinct mutational signatures emphasize specific genetic substitution patterns for each patient subset. These patterns are masked when looking at the full combined cohort. So when you look at the entire cohort of patients in gray, we do not see any particular interesting genetic substitution signatures except for the regular H clock-like related signatures. But when we stratified into our IDH, KRAS, TP53, and undetermined groups, we start to see unique association of the genetic substitutions. The undetermined group, counting approximately 50% of all the patients, are very similar to the combined cohort of samples, and therefore did not show any specific enrichment. For IDH, we see a signature 18 and 28, which are related to oxidative stress. KRAS, we see a signature 2 and 13 related to ApoBec, and P53, we see a signature 22 that are related to stratific acid. So specific genetic substitution patterns direct unique network perturbations. The unique mutational signatures are also related to the specific functional pathway association. This unique pattern is seen in each layer of the data that we went through, mutations, copy number alterations, the transcriptome, as well as DNA methylation. I will not go through each of these data layers with you since the paper has already been published. But what is striking and seen in all layers of data is this very specific enrichment of different signaling pathways or functional pathway association for each of the driver groups. So in IDH, we have, not surprisingly, maybe a degree of association with metabolic pathways and so forth. And in the undetermined group, I want to stress, as I highlighted earlier in the talk, we only saw an association with the mTOR signaling, and that still becomes important later in the talk. So we take this into a final step in the final step to determine if the specific pathway association corresponds to unique drug sensitivities. that may be exploited clinically. So we first matched the cell models in the lab as closely as possible to the patient groups using a full mutational signatures and NMF clustering. So they're not just matched based on the driver mutation, but also as closely matched to all the following mutations as I showed in the Venn diagram earlier for the patient set. Then we tested a library of 525 drugs that are either at the point of the study FDA approved or in late stage clinical trial evaluation. And we determined the drug sensitivity score, or termed DSS, determining the antiproliferative effect, optimal dose and therapeutic window for each of the drugs compared to normal cholangiocytes. And as can be seen when we sum the effective in the sharper yellow color is the more effective, whereas the more reddish color is the least effective using C-score. Each of the different categories have a unique drug association. So IDH, KRAS group, TP53 group, and the undetermined group. And then we added a fifth group, a group that had a cytokine that had multiple mutations, and to see if we had an additive effect of the drugs by having an IDH and a KRAS, or if we would evaporate the effect of the drugs. And what we saw was that when you have more than one of the driver mutations, you do not have any of the effect of any of these drugs in inhibiting their growth or their proliferation. When we sum the drug response versus the biological response processes, we see a unique driver gene subgroup enrichment of the recurrent genomic alteration that minimizes the heterogeneity and elucidates the unique regulatory pathways, and to a large extent can be targetable. And for each of the group, we see a unique drug class or drug category that are effective in each of these driver gene groups. So in IDH, we have RNA synthase inhibitors, we have microtubule modulators in the KRAS group, we have topoisomerase inhibitors in the P53 group, and in the undetermined group, we have mTOR inhibitors. In fact, we have a total of 7 mTOR inhibitors that showed a very high effect in this group of patients, and the mTOR was the only pathway we saw in the earlier data being upregulated in these patients. When we have them mixed, as I said before, we see no effect. And in fact, if you remember, I also said that the undetermined group were the group that was associated with the FGFR2 fusions. So it's not clean for FGFR2 fusions, of course. But when you look at the FGFR resistance to, for example, ifegratinib, you start to see an acquired extra mutation in FGFR2, as well as activation of the PI3AK2 mTOR pathways. So that could indicate that for FGFR2 fusion positive cases that falls into our undetermined group, one actually should consider combination therapy with FGFR2 inhibitors and mTOR at the same time or sequentially. So with that, I will move to the second part of the talk, that is to discuss the diagnostic and prognostic application of biomarkers, and particularly into our study from last year on the IL-6 as a prognostic biomarker and IL-6, IL-6R as a therapeutic target, possible target in biliary tract cancers. So as you all know, there is probably one could say an appalling lack of markers or biomarkers in biliary tract cancer or in general in the bile duct system. Even though we can use CA19-9, there is a number of patients, approximately 10% that are Lewis antigen negative, and their CA19-9 would not be useful. Besides that, we also have potential to monitor, for example, the NLRs and the neutrophil lymphocyte ratio, as well as the C-reactive protein. So in the next section, I will be relatively fast since there is limited information on these biomarkers. Most studies are performed in very small cohorts, are investigative, testing new research ideas or areas. or samples are not sampled correctly according to remark. That should be kept in mind for a biomarker study. In BTC, we are left, as I said, with CA19-9 and a marker that may probably are better as a prognostic marker monitoring the therapeutic response than actually as a diagnostic marker. At best, CA19-9 can aid diagnosis with a specificity and sensitivity in the range of 60%, and that is nearly close to a flip of a coin. So why is that? Probably because CA19-9 is increased already in benign disease and inflammatory conditions such as cholangitis, and of that matter also elevated in other malignancies such as pancreatic cancer. We have not been able to take many biomarkers to the clinic or any biomarkers to the clinic with various different serological, histological, or predictive gene signatures yet. When this is said, genomic testing or testing for the putative predictive marker is crucial for biliary tract cancers or cholangiocarcinoma to inform or support the clinical decision making and guide the best optional therapy forward. BTC is characterized by a dense dysplasia as part of the tumor microenvironment or TME. Here, chronic inflammation plays a crucial role in promoting the cancer by interaction between the cancer epithelial or stromal compartment. Such a crosstalk is coordinated by pro-inflammatory factors in which the IL-6 plays a cardinal role. The before-mentioned ABC trial showed already an elevated IL-6 in the BTC diagnosis, and various research groups have in the past studied the mechanism of IL-6 or IL-6 STAT3 axis, among those Professor Goris, and their the role in cell-cell communication. In the next slide, I will discuss the utility of circulating inflammatory markers in the IL-6 axis, including IL-6 itself, as well as a protein called YKL-40 that's involved in the IL-6 response axis, as well as the potential targeting IL-6 axis as a therapeutic aim. In this study, we included 452 advanced biliary tract patients from 3 Danish hospitals enrolled between 2004 to 2017. Patients were, and I should say, all samples were obtained and stored according to remark for a biomarker guided study. Patients were divided into a discovery and a validation cohort in a 2 to 2.5 split, and patients all had advanced BTC, so either locally advanced or metastatic disease. In the total, we evaluated 1,590 serum samples analyzed for the 3 markers IL-6, YKL-40, and CA19-9 at the time of diagnosis, so pre-treatment, as well as in a continuous variable until progression of the disease. YKL-40 is a chitinase 3-like 1 glycoprotein that which plays an important role in the inflammation by remodeling the extracellular matrix. It plays a role in angiogenesis, in protection against apoptosis, and involved in metastasis. And importantly, YKL-40 induces various cytokines, among those IL-6 itself. According to the pre-treatment clinical characteristics, both in the discovery and in the validation cohort, are overall comparable as seen here. Since there are no reference threshold for the prognostic utility of IL-6 or YKL-40 in patients with BTC, we stratified the patients into tertiles, so T1 to T3, and tested their association with progression-free survival and overall survival. Addition of one or several elevated biomarkers showed progressive association with poor clinical outcome. To describe the ability of these markers to predict death at 1 year, we performed ROC curve analysis, whereas the ROC curves are similar in the smaller discovery cohort. AUC values were substantially higher for IL-6 and YKL-40 compared to CA19-9 in the validation cohort. Post-hoc analysis of the ability of these markers to predict survival from inclusion and across all time points up to 3 years suggests that the pre-treatment CA19-9 is best to predict long survival above 1.5 years, whereas pre-treatment IL-6 and YKL-40 are better at predicting survival at shorter survival, so at less than 1.5 years. This suggests that inflammation at the time of diagnosis in the advanced BTC is associated with rapid deterioration, and the higher IL-6 YKL-40 potentially can be used to upfront identify patients with a poor prognosis. Accordingly, we were able to set a threshold for each of the biomarkers predicting overall survival at 6 months with a specificity of 0.85 or 85%. As such, patients with lower concentration of IL-6 have a better prognosis. So in the previous, we speculated that inflammation at the time of diagnosis is associated with rapid deterioration of advanced BTC patients. Next, we correlated IL-6 with inflammatory readouts such as CRP or NLR, neutrophil to lymphocyte ratio. Whereas both CRP and NLR correlate with IL-6 and predict shorter overall survival in the upper tertile, neither CRP nor NLR are independent predictive of overall survival. Comparing all biomarkers with CA19-9, IL-6 was the IL-6 was the only marker in the multivariate analysis found to independently associate with overall survival with a hazard ratio of 18. And I'm sorry, it's a little fuzzy in the table. Here I show the characteristics of the pre-treatment samples at diagnosis, and I marked the most important part of the table, as well as the time variable longitudinal sampling, which only shows significance of IL-6 with progression-free survival and overall survival as the only marker. Finally, we wanted to evaluate IL-6 receptor as a therapeutic target. We first analyzed the response of IL-6 to standard of care, so gemcitabine. As such, we developed gemcitabine sensitive and resistant cell line models and saw that the gemcitabine resistant lines showed an increased IL-6 response both by mRNA and protein in the media. I'm not showing that here. This analysis suggests that the inhibitor of IL-6R may counter the gemcitabine-induced IL-6 during chemotherapy. So we assessed the effect of anti-IL-6R using tocilizumab and anti-IL-6 alone or in combination with gemcitabine compared to vehicle or the control in vivo using a simple transplantation or xenograft model in nude mice. As such, IL-6 may not be a traditional driver. However, our data suggest that it is implicated in the degree of response to gemcitabine, and that inhibition of the IL-6 receptor may prolong the duration of chemotherapy, as we see a decrease in the tumor growth. So here I'll end the first two parts and conclude. So Serum CA19-9 is the most investigated prognostic biomarker in BTC, but 10%, we have to remember that 10% of the population that is antigen negative do not even express CA19-9, so it's a relatively poor marker. BTC is a desmoplastic malignancy in which chronic inflammation plays a key role. Therefore, circulating inflammatory biomarkers such as IL-6 may hold important prognostic information as well as therapeutic potential. We have shown that rapid IL-6 increase during chemotherapy is a poor prognostic indicator. Anti-IL-6 extends response to gemcitabine in our mouse xenograft model, and currently there is an ongoing clinical trial at a hospital here in Denmark using adjuvant tocilizumab, or using tocilizumab adjuvant in BTC patient management. In BTC tumors, we see prevalent oncogene addiction of receptor types and kinase pathways, and there is a potential for therapeutic application in KRAS mutated cholangiocarcinoma to revisit TKIs in a refined or stratified group of KRAS mutated cholangiocarcinoma. In intrahepatic cholangiocarcinoma, we observe a high prevalence of cooperative mutation in epigenetic regulators, so there is also a potential for epitherapeutic strategies in this disease. Now I would like to shift gears both in techniques, so into serum lipidomics, but also to hepatocellular carcinoma, trying to convey to you our newest work on the development of a serum lipidomic diagnostic score in NAFLD-HCC. We chose to change from cholangiocarcinoma to HCC since the etiologies in hepatocellular carcinoma are better defined than they are in cholangiocarcinoma, and therefore we will get cleaner data, was at least the rationale, if we studied NAFLD-HCCs. So in the last few minutes, I will like to dwell on serum metabolomics and its use as in diagnostics. I specifically chose serum analysis over tissue metabolomics because if a biomarker is to have a potential in diagnostic, it needs to be easy, non-invasive, and have potential in use of screening or surveillance applications. And as I said, I have here chosen to change from cholangiocarcinoma to HCC due to the refinement of etiologies. I've chosen a few studies that have been published as background. These studies agree both on the fact that we have an overall altered hepatic lipidome, regardless if you compare healthy to cholangio as well as HCC, or you compare healthy to cholangio or healthy to HCC. Interesting, they also speculate that the cause of inflammation are associated to an upregulation of IL-6, as we discussed in part 2. So considering previous data, where I showed you IL-6 as a prognostic marker of poor prognosis, as well as a potential for a treatment decision, and as well as a therapeutic target or targeting that axis. There is a link between these changes, inflammation, IL-6, and potentially the hepatic lipidome causing it. The main risk factors for developing HCC, as you know, are viral hepatitis, alcohol, and metabolic disease. We have, if you look over a period of approximately 15 years, seen a sharp increase in NAFLD or metabolic associated disease in that period of time compared to the other etiologies. Often NAFLD or other metabolic disorders are not surveilled, which typically is due to limited cirrhosis or much lower degree, whereas you often have cirrhosis on the background of hepatitis or alcohol. You have a very low degree of cirrhosis, or very low number of patients with cirrhosis in NAFLD associated HCC, at least lower than 30%. So we set out to develop a non-invasive biomarker for surveillance or early detection of NAFLD-HCC. Here we used a comprehensive serum metabolomics-based approach to identify unique NAFLD-HCC biomarkers, allowing us to distinguish early NAFLD-HCC from patients with NAFLD or HCC on a background of alcohol or viral hepatitis. We call them AV-HCCs. The study population was 249 serum samples. The discovery set was 196, including 27 NAFLD-HCCs, 32 AV-HCCs, 102 obese NAFLD patients, and 35 healthy. The validation set was 53 serum samples, including 37 NAFLD and 16 NAFLD-HCCs. Our NAFLD-HCC sets include a patient with biopsy-proven diagnosis. They had self-reported alcohol intake of less than 20 grams per day, and they were negative for all hepatitis B, C serology, including surface antigen, surface and viral core surface and viral core antibodies. So they are with a mono etiology or mono risk factor of NAFLD compared to in many studies where the etiologies are mixed. And that was one of the key reasons for changing to HCC, to have a clear association of the etiologies. Samples were again sampled and stored under the mark, and we used mass spec analyzing 1,295 unique metabolites, mainly focusing on the lipidome. This is the workflow we went through. We first identified the number of metabolites we could detect out of the 1,295 on the libraries. That was 470 metabolites. Then we corrected for BMI, age, and gender, and we investigated a number of other underlying causes for the changed metabolic profile, such as cirrhosis and diabetes. We generated a general linear model. We evaluated the metabolic landscape of the differentially expressed metabolites, progression from healthy to NAFLD-HCC. Then we developed a diagnostic model, including 14 metabolites with an AUC above 90.9. We did a support vector machine to identify the 5 best metabolites among those, we identified the 5 best among those, and we tested those against an external NAFLD validation set of 37 NAFLD samples. Then we developed a NAFLD-HCC diagnostic score on NHDS. We quantified the metabolites among the 14 where we could find a commercial standard. So in total, we were able to validate or quantify 10 metabolites. And we took it through to develop the score, the NAFLD-HCC score, and evaluated the score's performance in the full cohort. Already using both sparse partial least squares discriminant analysis as well as hierarchical clustering, the NAFLD-HCC subset is most dissimilar compared to the other groups, control, obese NAFLD, as well as the alcoholic viral HCCs. The 14 main metabolites are mostly fatty acids and showed an AUC ROC curve of above 0.9. These perform better than both alpha-fetoprotein as well as liver functional markers such as ALT, as shown with the ALT as well as AFP in the dashed lines, and our model is shown with the full lines in the ROC curve, as well as a higher predicted accuracy for healthy controls, obese NAFLD group, as well as the HCC on the background of viral or alcoholic-related disease of 93, 97, and 96%. Next, we attempted to validate the diagnostic metabolites. The validation set was estimated based on sample size calculation to be able to validate the diagnostic metabolites we identified in the previous slides. And we used commercial standards to establish the relative abundance or the quantification of these metabolites to establish a cutoff value to develop the diagnostic score. The forest plot presents the odds ratios as well as the relative risk of the score based on the cutoff values. Finally, we performed a pairwise comparison as well as investigated the progressive metabolic perturbations from healthy or the control to NAFLD-HCC, mainly showing a unique drop in fatty acid families as well as an increase in triglycerides. In conclusion, the depletion of unsaturated fatty acid and the increase of triglycerides are at the core of the deregulated metabolic networks of NAFLD-HCC, leading to an altered signaling and likely dependent nutrient utilization of the cancer cells. These changes can be exploited, we believe, for non-invasive surveillance of patients at risk of early HCC detection in the background of metabolic syndrome, such as NAFLD, diabetes, or morbidly obese patients. Not to forget, these are the people in my group who are doing all the work. I would also like to thank all our collaborators, particularly Xing Wang and members of his lab for hosting Dan Høgdahl during his secondment while performing his MD PhD, and that was on the IL-6, IL-6R study. And thank you for all of you for listening.
Okay, thank you so much, Jesper, for a great presentation. Really comprehensive assessment of very heterogeneous tumor types on multiple levels to try to find signatures and biomarkers. So we'll open it up now for questions. If you have any questions, please put them in the chat or let us know that you have a question and we'll call on you.
Can I see the chat as well? Yeah.
You should.
Yes, but that was very interesting, especially the IL-6. And I have a question regarding the IL-6, because as you know, from a clinical perspective, one of the main issues we have with these patients is cholangitis.
Mm.
And a lot of times our patients actually die from chronic cholangitis rather than from their cholangiocarcinoma. And I wasn't sure when I looked at your data, whether, you know, how you dealt with this problem, because that's obviously a clinical parameter that needs to be taken into account when you talk about IL-6, which obviously it doesn't apply to the mouse model and the therapeutic approach, but for the biomarker, yeah, it may be quite relevant. And just the fact to say that these are all intrahepatic cholangiocarcinomas, you know, clinically we still know that depending on where they are located, some patients just have more issues and problems with jaundice than others.
Yeah, that's a great question, Tim. So we associated or tested tested IL-6 and its elevation in comparison to CRP and NLR as routine markers measured, or routine numbers measured in the clinic here. We do not have cholangitis at a high degree, and that could be really interesting to actually expand with a PSC cohort. Both PSC we know that progresses to cholangiocarcinoma, as well as PSC that have not progressed.
But you also may want to include the bilirubin, not only the inflammation.
Yeah, I believe you had bilirubin as part of it. I'm quite certain of that.
Okay. Are there any other questions for Jesper? I don't see anything in the chat. So you can also turn on your video and ask your question if you like.
I talked them all to sleep.
So Jesper, you showed a bit about your serum lipidomics at the end of your talk, showing the importance of some fatty acids in the serum. Have you done any sort of, or do you plan to do any integrative analysis, looking at some of the gene expression studies to look at you know, some of the pathways, enzyme networks that are involved?
Yeah, so actually one of the requirements for the sampling we did was that you had surrounding tumor tissue serum and you had to be what I call this mono etiology, so no viral hepatitis, no alcohol history, at least based on what you can expect from a self-reporting situation. Since the serum diagnostics worked out, at least what we believe worked out so quite nicely, we actually did not do what I had envisioned, making one big paper of everything, because we thought it would be too complicated to tell that story. And we chose to write a serum diagnostic paper first, and that could be maybe, to be honest, wrong. I don't know. It's hard to sell diagnostic biomarkers, even though everybody wants them. But we're still trying. So the answer is yes, we will integrate, but I will integrate the serum. I will integrate the metabolomics on the tissue level, not on the serum, because what goes on in the serum is not necessarily what goes on in the tissue as a one-to-one. I'm certain you have seen that as well.
Fair enough. We have a question from Jill Koshiel. She says, really interesting work. And as you know, one of the difficulties with studying biliary tract cancers is that there are a diverse set of cancers that are rare in most parts of the world, and wants to know if you have any thoughts on how to collect more cases.
Well, I think the only way to go forward is what we have been doing, Jill. And for that matter, many of the rest of us as well, is to collaborate. It's also one of the reasons for when I came to back to Europe after many great years in US, and I went to the first European Association for the Study of the Liver. There was one case story on cholangiocarcinoma. One shouldn't say poor story, but there was one lady with cholangiocarcinoma that was presented in some corner of a very big conference, and so we sat down 10 different people from 10 different European countries and decided we should do something to get a bigger voice. And I think we have gotten a bigger voice, at least on the summit. It's not called HCC summit anymore, it's called Liver Cancer Summit, including cholangiocarcinoma, and many of us have been co-organizers of that summit under IASL over the years. So the ENSCA, the European Network for the Study of Cholangiocarcinoma, has, as a grassroots organization, actually been quite good in that relation. It also, it's not published yet, but it's ongoing in review. So we developed with Jesper Andersen in San Sebastian, Spain, as the head of that part, a patient registry for cholangiocarcinoma in Europe. Data registry, not actually getting the samples there, but the samples have to be available in the contributing departments. And there, I think he's around 4,000 cases. And hopefully soon a journal will accept this epidemiology type study. So this should be interesting for Jim, at least.
So I have another question regarding your lipidomic studies. So, obviously, as you know, we're doing a lot of mouse studies, and we're always criticized for using the wrong diet in our mice, which may affect and lead to different results. But actually, I'm going to throw this back to you because we know, for instance, in the United States, there is a very high rate of fatty liver disease in Texas, and that's basically corn related. And that may be very different from Europe or Asia. So I was wondering, what your thoughts are. How does the signature that you apply, or that you've identified, apply to? Is this limited to a specific diet or not?
Again, a great question and a tough one, I have to say. Well, I can start by answering. First of all, this is a Caucasian cohort. It is a Caucasian cohort that counts samples in Europe, mainly France and Spain, but are also Danish as well as Chilean and Brazilian samples in there, but all Caucasians. Currently not including any US, but we are trying to get some from Mayo Clinic to test against this as well. We know from most of the studies that have been published on larger metabolomics studies on NAFLD cases, I think nearly all, there are few only, but they're all from Asia. That one thing that is very different in our cohort, and I believe that must be due to the Caucasian compared to Asian, is that their circulating are completely flipped. Why? I'm not sure. Diet? I can't answer, but that's interesting. But yes, there are things in US and many other great studies on NAFLD-NASH associated HCC or before you even develop HCC in the mouse model, where some of the preliminary data we see in the patient data, we do not see all of it, but it's not to be expected, right? That we have a fully matched model. It's not happened yet in any, neither cholangio nor HCC models that they are that well fitting. But they are good to use anyway for getting as far as possible.
Yes, but
so I didn't answer your question fully. I'm fully aware of that, because diet we don't really have any information on.
That's okay. Thank you.
Dr. Hassel?
Yeah, thank you. Yes, but great talk. Good, really impressive amount of work. So I liked on the kind of model topic, I liked your use of identifying cell lines that mimicked to some extent what you see in patients. Can you then go on and introduce mutations to other candidate targets? Is that something that's in the works, or do you think that that would be worthwhile?
To see if we then match the drug response we saw in a cell line that did not have the mutation, we can now develop the response.
No, actually, so your cell lines had a subset of mutations that were similar to the patients, and then what I wondered is, so maybe that is a sufficient model. Maybe there's another mutation that would add to the constellation and make it a better model. So then, would we use CRISPR or something to introduce those?
In line of this, we used the full whole exome sequencing and used NMF clustering. So basically, it's taking into account all mutational aspects of the cell line compared to the patient group that have, of course, also some heterogeneity when it comes down to the lower penetrant mutations. So I think we will be getting to the one mutation matching only one case. So what we have always called passenger mutations. They may be actually quite important, but I think it would be hard to study. And then one should probably just do lethality studies or something like in the DepMap repository situation where you can test on a whole CRISPR screen. So the answer directly would be no, but going more focused in our case, in epigenetic regulators.
Got it.
Because we see a lot of cooperation with epigenetic regulators of the different patient subsets. Of course, the IDH, that's an epigenetic regulator already, but there are also other epigenetic regulators in that patient group, as well as in the P53 and on the terminal groups that are epigenetic regulators that could be interesting to study for those patient sets. And there we do CRISPR screens.
Makes sense. Thank you.
Okay, I think we have time for just one last question, and it's from Bob Rue. He's asking, is the increase in IL-6 only associated with chemotherapy or with the progression of cholangiocarcinoma in general?
Poor prognosis in the high tertile. And that's why we tertile the patients, to get a split. Mm-hmm. So we cannot, I'm not suggesting we should use IL-6 for all patients, but it could be used to stratify out 1/3 of the patients that probably should be considered to be treated in a different way than we do today in random clinical care. Mm-hmm. But there's a lot of development in this area right now for patients. I think we have even overtaken HCC in patient grouping.
All right, I think we're going to end there. So thank you again very much, Jesper. It was a really fascinating talk and really great work on a field that needs a lot of exploration. And I want to thank everyone for their attendance. And again, just reminding everybody that we'll be back in the fall. So we'll hope to see you again in September.
Thank you very much for having me.
Thank.
I have to go over to the other one again, right?